you a woman in medicine feeling overwhelmed and disconnected from the personal fulfillment that you desire? You're in the right place. Join doctors Joanne and Erin as they rewrite the rules for women in medicine. Let's begin.
Some women in healthcare didn't just choose healing. They learned early how to survive, how to read the room, how to take care of others, and how to keep going. For some, their experiences as a patient shaped not only their interest in having a medical career, but also the way they practiced medicine. In this episode, we are joined by Dr. Diane Solomon, an award winning Harvard trained writer, Yale trained nurse midwife, and Oregon Health and Sciences University trained psychiatric nurse practitioner and PhD. She's a graduate of OPC's psychodynamic psychotherapy program and specializes in well-being, women's mental health, and adult psychiatry. She recently retired from clinical practice, is a writer, and well-published on psychological health across the lifespan, from HuffPost to the Gerontologist and MedPage Today. And she also writes an ongoing column, The Narrative Nurse Practitioner in Psychology Today. Welcome to the show, Diane.
Thank you. Such a pleasure.
I'm so excited to have you here, Dan, and all the things. I love that long list of accomplishments, and yet have you here, be with us, and of course, all the mental health love. Then it's so important. Thank you.
And before we dive into our conversation, this is just a gentle reminder for our listener. If you haven't yet given us a rating or review, please go to the show and give us your honest feedback. We read every comment and would love to hear how we can serve you better. And with that, Diane, you and I had a great conversation yesterday over lunch, and I wanted to share some of your unique perspectives as a healthcare provider with our listener. And as I shared, many people enter healthcare for different reasons. And when you shared some of your background, including an article in the Huffington Post that was published in February of 2023, you shared a unique perspective because of some very severe health issues you suffered with as a child. And it brought up the topic of how the actual medical system can be the source of trauma for patients. And I would love for you to share with our listener one of the stories that impacted you. And so we can also talk about, with so many more women going into medicine, what are some of the things that we might be able to do to impact this in a positive way?
Thank you so much, Erin and Joanne. It's really great to be here and to talk about these issues that are so critical. I am under 5 feet. As a child, I had life-threatening asthma. No one in my family is short, and basically a malpracticing allergist gave me steroids and ACTH shots that stunted my growth. And when I was about 8, my parents figured that out, and with the help of the pediatrician, and took me to Scripps Clinic, very famous in San Diego, and started this basically life of testing. And when I was 16 or 17, inhaled steroids went on the market for asthma. So that was a game changer for me. And my parents sent me to an endocrinologist to see if, maybe they could promote my growth or do something. So I wouldn't be, technically I'm a dwarf, I'm under 4'10". And I went to the endocrinologist, and he came in the room. I was in my gown, and I was seated on the exam table on that crinkly white shiny paper. And he came into the room, and he was followed by half a dozen men who, in white coats, residents or medical students, what have you. And he said, "Please drop your gown. You don't mind, do you?" And after, decades, more than a decade in medical treatment at this point, I had learned to do what the doctor said. And so I dropped my gown, and he was using me as a model of basically proportionate dwarfism, which is not like the syndrome of dwarfism, but someone who's under 4'10" with normal proportionate legs and arms. And not only did he talk about that, but he talked about the development of my pubic hair and how my breasts were and all my secondary sexual characteristics. And he's, doing this all in the third person as if I'm not there. And then he says, thank you. And they all file out.
In one detail I know from reading the article, Diane, that I don't think you mentioned is he actually asked you to stand on the exam table.
I'm sorry. Yes. First he said, can you stand up? Well, I was still clutching my gown. And then he says, drop your gown. Yeah. So, and it's very unusual for me to be above anybody, but there I was, like on stage naked.
And I can imagine at that age where we're finding ourselves, and it's right, like we're so conscious. I mean, not that that would have been okay at another age, but that particular age where we're still overly conscious, our self-esteem is forming. You already had to deal with years of treatment and feeling different, I imagine, to be there. I don't know, right? Like it's feeling violated in a way. That's a big word, but.
Yes. And of course, at the time I didn't know this. I notice right now I'm sweating. I'm hot. You can see I'm sweating just talking about it. And at that time, they walked out of the room and I kind of just stood there. I'm sure I felt very ashamed. And I didn't know, what to think. Of course, I had no context for realizing this was traumatic.
I want to bring this up is because I had shared with the two of you before we started recording that I was watching on social media, and is it Ashley Judd, who was in Double Jeopardy, the movie, and she's talked very openly about trauma, sexual trauma that happened in the modeling and in the movie business. And she shared, I think she was flown to Japan as a young teen for modeling, and talked again about, she had, I think, her bra and underwear on, but being paraded around in front of a room full of men, basically being visually assaulted.
Yes.
No one there to protect her. And it's this, attitude of, well, you knew what you were getting into. Who says that gives you permission? And there's nobody, she's not there with her parent. There's nobody there to protect her, just like there wasn't anybody there to protect you. And I think, like, most people think of the entertainment industry with the movies and modeling very different than medicine. But I thought, holy cow, this is a shocking similar thread that doesn't make me feel good as a physician. Yeah. And I think if we're not talking about these topics, then how are we going to change them?
I think that's such a good point. And I have a current story. It's very different, but I think it really is pertinent to this, told by literally my hairdresser. I went in there last week. You can tell it's super short. And she recently had a baby. And I was asking her, I'm a nurse-midwife, so I wanted to hear her birth story. And she just started by saying, they gaslit me. I had an anesthesiologist who was a woman who came in and said, hey, I got to do a surgery next door. If you want the epidural, you need to have it now. And then 15 minutes later, my hairdresser says, I was doing fine. She comes back and says, hey, I'm going to have to leave. If you want the epidural, I have to do it now. And her husband, of course, got the fear from the anesthesiologist and didn't want to see her in pain. So it was encouraging her to do it. So she did it. And then she said, and then I couldn't feel anything. She really had wanted a natural birth. And then she said the OB came in, also a woman. And she said, hey, my hairdresser, I'm not going to name her, said, I really would like to get on my hands and knees. And the OB said, well, why don't we have you on your back at first, which is totally physiologically not congruent with the way women have had babies through the ages. And let's just start on your back and see how it goes. So she started pushing. And then she said, okay, I'd like to get on my hands and knees now. And the OB said, well, you've already made so much progress. You're committed here. Let's keep going. And I totally get this from the medical point of view. Excuse me. Women physicians are basically trained with this model that they're supposed to do it this way, and they're the ones in control. It's different than a nursing model, and they're exhausted. And even a patient giving birth who wants a natural birth and who wants to try standing up or getting on her hands and knees or something else, it's just too exhausting even to think about for the provider. They just want to get this next baby out, and then they have to move on to the next thing. There's nothing wrong with these women physicians, but it's the system.
Yeah. And I'm hearing like a thin line of following what we learned and the doctor programming that we talk about, and right, like it, and though we know better because we're the ones trained, right? Like assuming that there's a little bit of that, good and bad.
Yes.
And then where do we take in the patient's wishes, which should be 100% of the time. Of course, I'm a psychiatrist, so patients say, I want 10 milligrams of Xanax a day. That's not a patient wish that I'm going to follow. So of course, I'm exaggerating on purpose. So there's that thin line, right? But then it's having the empathy of listening or maybe explaining it different, right? Like I imagine that we could argue on either side, but to then have, right, like her tell you, I feel like they were gaslighting me. I mean, those are big words, right? Like that's not the story you want to tell about a childbirth, right?
Exactly.
It's such an important day.
And I see too, this individualization. This reminds me of my sister she was a teacher for quite some time down in LA, and she did a special ed class, and every one of her kids had a different need. So she had a different classroom plan for every child in her classroom, and IEPs for all of the children in her classroom. And so when you think of the extra work that's needed, I don't think she was paid any extra to do a different care plan, like, a regular classroom would just have one class plan. And so when you think about the added demands of if every patient delivering wants a different birth plan, and the added workload that puts on these physicians and healthcare teams that are already stretched to the max, it makes me think, okay, what was the staffing like? What was the nursing ratio?
Yes.
What was the, how many hours was this doctor on? Were they used to having multiple OBGYNs and anesthesiologists, and now they only have one? So they have to, the work has to get divvied up. And there's always two sides to this.
Absolutely.
And just seeing the state of medicine, that it's like the straw that breaks the camel's back, right? You're being asked one more thing, and the patients don't necessarily know what's going on behind the scenes in medicine, and how would they? And yet there's, the human side to both stories.
I have to say something, because what you said about your sister is fascinating to me, because if you look at traditionally female dominant professions like teaching and like nursing, and then you look at medicine is still taught. It used to be, traditionally very white male dominant, and it is still taught through that lens. But I don't know that much about teaching, but I know the difference in nursing or nurse midwifery care, for instance, for birth versus, and any nursing versus the medical physician model, is that nurses are taught first to look at the patient as a whole being. And when you're taught to do that first, it's easier to be more patient-centered. Like you're looking as a nurse midwife for this particular woman who's healthy. She didn't have a lot of issues. The nurse midwife would go in there wanting to give her the birth that woman wanted because that was the training. Whereas the OB is taught to go in there, and this is the tragedy, and get that baby out, and it's supposed to be out in a certain amount of time, and the easiest way to do it is this, and et cetera, et cetera. It's a tragedy that medicine, I think, still has that male dominated, we are at the top of the pyramid hierarchy. And I think that's one reason why women physicians, I mean, nurses too, are very burnt out. But it's the reason for your whole podcast and your wonderful coaching is that women physicians have a hard time. We know they take better care of patients than males do. We have the research that shows they get better outcomes. And at the same time, I think they're trying to put their round peg in a square hole that does not really fit them very well. That was a lot. Sorry, but
and going back then, thank you so much for sharing like your story earlier on, because it's and I'm glad that maybe my brain worked differently all along. I don't know, maybe my love for in mental health and connecting with the patient. But it's funny that I went into medical school wanting to be a psychiatrist, but my second choice was OB-GYN. But I think it was all the social service and patient connection that I was able to do in my rotation. And I trained in a county hospital, big county hospital in Puerto Rico, and we saw everything. And it was kind of like what you're saying, that it's the attending, like the upper level resident, lower level, the students, all of it. And because we saw uncommon things, I have clear memories, and this is going to sound a little graphic, but like someone getting a gynecological exam, and she's there with, how do you call like the thing to open the cervix?
Speculum.
Thank you. Yes. And because she had and I even remember the diagnosis, and it's a strawberry cervix, and I don't remember all that meant, but so they literally called all the students and all the residents to come in while this poor, and of course they asked her, but right in the most vulnerable literal position. And I remember, and they were, and I remember clearly, I went to medical school the last century, and I remember thinking, is no one worried about her? Like, isn't anyone saying like, okay, that's enough, right? Like,
yes.
Enough people looking at your cervix, like it's this thing. Oh my goodness. So and there were so many things like that, but I remember that one clearly, and I just like stood next to her. Like, I don't know, it's like, I think what I gravitated to very instinctually early on in my career, right? So but and I don't remember that I said anything or that anyone said anything right after, but how sometimes that happens, and it's inevitable, especially if you're in a teaching hospital. But, like in we can all talk about this, and we all have experience in trauma, in that how you can experience something very traumatic, and one positive encounter right after can make such a big difference in terms of, right, like a safety grounding encounter afterwards can change literally the wiring in your brain of how you remember that memory. And maybe even if you had another nurse, right, like right there next to you saying like, that was a lot, let me help you get dressed again, are you okay, do you need anything? I don't know if you were able to get anything like that, but
just to be validated that, wow, that was a lot.
And
like
it's a message, right? Like if we say like, how can we make, right, like we always try to bring it back to the present and then say, and how can we make it better? And the message of, as physicians and nurses, this is our responsibility with what we know to make it different, right? Like we cannot change that. Probably things like that still happen, and that if some
Right.
of us have awareness, how can we keep on spreading the word of, how can we
And
respect patient wishes differently? How can we make them feel safe? How we can give them that feedback right afterwards to bring them back to grounded.
exactly. And, we are human. We're going to make mistakes as providers. And something I learned in my psychiatric career was that if I reflected on a mistake and I realized, wow, I really wish I would have done that differently, even if a year had passed, I would try to contact the patient and say, I am really sorry. In healthcare, well, maybe not now, it's starting to change, but generally we're taught never say you're sorry, never admit you are wrong. They can sue you if you do that, blah, blah, blah. And I think that's so wrong because patients only sue, that's kind of the extreme, if they walk away feeling unseen and unheard. And if one person says to them, like exactly what you're saying, Joanne, wow, I don't know how you did that. You are really courageous. I don't know if I could have done that. Uh, that's all it takes. Or like I did or tried to do, because I really reflected, is probably obsessed maybe. Oh my God, I can't believe I said that or did that. And we're all going to do it. But to be able to go back and repair and just say, I am really sorry. That was all on me. You did nothing wrong. And is there anything I can do now to make it better? And mostly patients would say, I just really appreciate you saying that.
Wish we could do more of that. And we can always acknowledge their experience. Right? Like,
Yes, that's all we're doing basically, is acknowledging their experience. And now in the malpractice world, they have people at hospitals, ombuds people, and others who are trained to go in and apologize like that, because so often the providers don't know how to, and they're hired and trained to do that to discourage lawsuits, which of course is not doing it for the right reason. But to the patient who feels heard, they often do let go of their grievance or their trauma. And there's so much trauma perpetrated in the name of healthcare through history. I mean, I just have to say the word Tuskegee. It's embedded in the system, and yet at the same time, people like you two are teaching providers and modeling for them how to do a better and more humane job as far as their selves are concerned, the providers, to be able to maintain and have a career that's sustainable. And that's always better for the patients that they care for.
Diane, I'm going to go back to the start of our conversation when we talk about how our own experiences, either from maybe it's childhood trauma or maybe it's trauma from our experiences as a patient, can shape us going into medicine and also how we practice medicine. I would love to hear from you. How do you feel like your experience, as you said, you had life-threatening asthma, and then you had so many interactions with healthcare teams. How do you think all of that over a decade, as you shared, impacted your career, both as a nurse midwife and then as a psychiatric nurse practitioner?
That's such a beautiful question, because how many people do you know, how many medical healthcare providers went into healthcare maybe not their own experiences, but because they watched their mother suffer with cancer, or, their brother was tragically killed in an accident and they couldn't save him, or what have you. I think that's a really beautiful reason to go into healthcare. I think where the difficulty comes is when we as providers are not aware that that informed our decision making for why we chose healthcare, and we try to have healthcare heal the wound and are helping others heal the wound inside us that brought us to healthcare, but has never been directly confronted. It might be subconscious. So in Joanne and my language, people have not gone to therapy about this. They're not even aware that they took that childhood trauma that happened to them personally as a patient or to a family member and decided, okay, I'm going to try and heal this by healing others. And I think what we need to do, and what I love to do with healthcare providers, is help them unpack that. For instance, there's just beginning research that people with higher ACE scores, and I'll explain what that is, tend to go into healthcare. Now, ACEs, adverse childhood events, ACEs is a scale of 10 questions of things that did or didn't happen to you before you were 18. And the ACE scale has been validated a bazillion times. It came out in the mid to late 90s, and it's very well respected. And it asks questions like, did your parents divorce? Was there substance abuse in the home? Were there mental health issues in the home? Was there assault or abuse in the home? Did you feel neglected? That's not the word it used, but basically there's 10 questions like this, and you get a score, and the higher your score is, the absolutely higher the chances of you as an adult having chronic illness, substance abuse, obesity, cigarette smoking, cancer, everything. And I know that nurses go into nursing because of a lot of trauma. One of the earliest times I became aware of it, look, I did my nursing training in the mid 80s. I was like 16. But in any case, nurses were the profession that smoked the most cigarettes. And here there's nurses, they would go in their break room and smoke a cigarette and then go back and talk to the patient, take care of the patients. And we know now that cigarette smoking can be a trauma response to a high level of adverse childhood experiences. So there's nothing wrong with people who have been hurt wanting to turn around and help others. That really is a beautiful thing. And they need to become aware and unpack and understand their own hurt to better take care of themselves, to be more resilient, to keep doing the work that they love and not get burnt out, and to absolutely be able to better take care of their patients and help their patients have better outcomes.
And I had the privilege of actually hearing Dr. Vince Felitti speak twice when he came to my town. I worked in child abuse medicine for a decade, and I didn't learn about the ACEs study, adverse childhood events or experiences, until I started working at the Child Abuse Center, which was, 15 years into my career.
Mm-hmm.
And so when I remember he specifically said, the reason why the graphs in his paper show 0, 1, 2, 3, and greater than 4 ACEs as your score is because greater than 4, it won't fit on the page. The risks raise so much exponentially higher once you hit 4 and above. It was just this shocking detail that that is enormous. And when I think about how little was talked about the effects of trauma in our lives throughout most of my medical career. And I'm happy to say when I did a training for a PA school about social determinants of health and about some things and brought up ACEs, they knew about it. They'd heard about it. I'm like, oh, thank goodness that we're starting to talk about trauma, because there's so many layers to trauma in medicine. As you said, the trauma we bring in from our own history, the trauma our family brings in, the trauma our patients bring in. And to me, I think better understanding trauma gives me such a greater understanding about behavior. I was just talking to a functional nutritionist this morning about a podcast interview I'm going to do for her next week. And we were, she's a functional nutritionist, deals with people who are dealing with overweight and obesity. And I was like, well, how much do you know about the ACEs score? Oh, a little bit. And I was like, okay, well, here's the deal. Did you know that for some people who have had maybe sexual trauma as a child, that extra weight is their protective factor? You take that away and they haven't dealt with their trauma and the weight's going to come right back on. And so it's just interesting that, again, this is just my lens. I can't unsee, can't take the trauma lens away because of, working in trauma for so long. And it's just alarming how little most people know, including in medicine, about trauma and the potential big impact it can have on behavior, whether it's post-traumatic stress disorder, right, where negative outcomes, or you can have post-traumatic growth. And as Joanne said, depending on were you supported or not, may play a huge role in the outcome.
Yes, I think when we teach about ACEs, at the same time, we need to teach that this is not a life sentence. Mm-hmm. You can get support, you can get help, and you can turn those traumatic experiences into post-traumatic growth and become resilient and teach that to your patients. One of the traumas you didn't mention, which I think is critical in healthcare, is the trauma of training, the trauma of becoming a healthcare provider. There's a lot of trauma in there. Like for you, Joanne, when that happened with that patient and everybody wanted, they brought a parade in to see her cervix, that was not only secondary trauma to you, but probably primary trauma too. You've never forgotten it.
Yeah. I felt that like I had like a total, very vivid memory, and it comes to my mind often, like every time, like I think, right, like the vulnerability of being a patient and also kind of how we train, right? Like the other side of it. And right, like I feel very lucky that I trained in that hospital, and then I did my residency in another gigantic county hospital in Houston, right? And I saw so many things and so much struggle, and as a psychiatrist, the ACE study was such an important thing because it was the first time, and then they extended it to 25, I think, years old.
Yeah.
The first time that it was very clear how something mental health related will affect your more physiologically. Before, I don't know if this was your experience, but then it's like, oh, psychiatry is like a cute thing that's, go see the shrink. It's in your head. It's not really important. And then like everything, the real medicine on the other side. And I remember being so sad, but at the same time, it's like, of course, we've known that forever, but now we finally have facts. And then, like you said, how can we turn that around and make it be something that's very hopeful rather than a life sentence, like you said, or like you're not a victim to it forever. You can use the awareness in your favor and seek different help. And for their caretakers as well, like you cannot just see something in isolated. Like here's you're overweight, go get on a diet. Like that's on you. right? And then so of course I'm, air quotes there, I wouldn't say that, but then saying, okay, let's understand these patterns of behavior. And could it, and I see it in my practice, you probably saw it, and that there's a reason why psychiatric care is part of bariatric surgery, and it should
Yes.
absolutely be part of all the GLPs. Like, I'm an advocate for that now. Of, are we providing psychotherapy and psychiatric care to all this fast weight loss that the GLPs are creating? Because if you don't go back to the patterns that created some of that, and I'm just using weight loss as an example, it could be high blood pressure, and like you said, even cancer. Like, we wouldn't, like before, be like, well, high blood pressure because they eat bad, because they're in a bad environment, right? Like, they could always trace it back to a choice. And now understanding, because part of the studies were, you can be moved to a different zip code with a different financial situation, and the risks remain. So they were able to cancel all those other variables that were more just social, right? And we could talk about this the rest of the time, because it's so much important information. I'm so glad that you explained it so beautifully. Thank you.
Well, I just want to say one more thing about ACEs. I used it with speaking to care providers and healthcare and medical providers, but I also used it with patients. I would go through it with them if they thought they were able to, because even the test can be very triggering. So I would always give a trigger warning. But over and over again, when I did this with patients, their eyes grew wide when I explained the whole thing, and they would say, I can't believe this. It was not my fault. It's not my fault that I'm obese. It's not my fault that I'm a smoker or an alcoholic or whatever. Not that absolves them of doing anything to help fix it, but for once to realize that what they withstood as a child, that, we all have trauma, but the ideal is to give our kids less if possible. And it was incredibly freeing to them just to know that and go from there.
And let me ask you, if we bring this back to women physicians, and kind of making that assumption that either before we chose medicine as a career, or what we experience, right? Like, I always wonder, how's my brain after all the stories that I've heard in the 20 some years that I've been a psychiatrist. But if we bring it back to, like we were talking in terms of the experience of, what are some things that you would say, instead of us over functioning and doing all those, like I call, like healthy denial coping skills that get us into burnout, what would be a better way or more compassionate way that you would recommend?
I think women need to understand that it is not selfish to take care of themselves first, that is self-care, and that they cannot serve anyone well if they aren't aware of their own needs. How can you help someone else with their needs, really, truly, on a deep level, if you're not aware of your own needs? So I think learning to pause before saying yes, just pause, just make yourself pause and say, I'll get back to you. Learn literally how to say no. You can say, I'd love to, but I can't, or learning that no is a complete sentence. Learning that you can only control what you can control. And you can control if your patient stops smoking, or, eats better, or starts exercising. You can support them, but you are not able to control them. And if you let go of that, it's a huge relief and builds your own resilience. Other things that people in healthcare don't do are take vacations. Don't go to work when you're sick. Stay home. Model that for your other colleagues. I think especially women in medicine think they have, because it's true, they've had to do more or be better just to get where they are. They don't see, it takes a while to realize I can let go of this way of being and start taking care of myself and be a good role model for myself, for my own kids who do as I say, not as I do, and for my colleagues. And that is really powerful. So did that answer the question a little? Okay.
Yes, we always talk about the importance if when you know better, it becomes a responsibility, right? When we have
Yes.
that awareness, and we talk so much about being role models and right, like walking our talk and
Yes.
right, like I sometimes have to remind myself, this is what you talk about. Are you asking for help?
And
Are you
that's
taking
really,
real rest? I'm like, oh yeah.
yes. And that's really good. If we talk about it, then we'll remember that we have to do it too. A final thing that I think is really important for us as overfunctioning, high achieving women is when we learn, okay, we're supposed to say no, or we're supposed to say, let me get back to you, or we're supposed to stay home when we're sick, or whatever it is. We think we should be able to do it like this. And it really takes time. You're going to say yes 6 or 7 more times before you even realize I'm supposed to say, let me think about it. And giving ourselves that time and telling ourselves that it's a process and that that's okay, that it's a process. That's the way it really sticks in the neurons. That is something that is a part of self-care and self-compassion.
Well, and I want to point out too, a topic that Joanne and I both bring up is in our one-on-one and our group coaching programs is who do you have supporting you? Because you might feel like a total outcast because nobody else in your office or in the hospital has boundaries. Nobody else says no. And I remember feeling that way when I first started working with my first coach. It was very isolating because nobody else is doing those things. And then I began incorporating it and role modeling it. And then after a while, I was leading walks around the neighborhood after we would do our morning child abuse evaluations, which was so much healthier than just dive in and do your report. We were moving our bodies. We were shifting our energy. We were getting outside in nature. We were socializing. And I just think, and then that became the new norm.
Yes.
And so then changing the culture so that it feels normal to take care of yourself. It feels normal to call in sick when you should instead of showing up, and
With
needing
a
IV
mask.
fluids or something. Yeah.
It feels normal to have a bad birth outcome and be able to talk about it or go in the staff room and literally cry or have someone hold your hand before rushing to the next room to deliver the next baby. It's true. We have to normalize all this because anything else is inhumane to ourselves and to the people we take care of.
Yeah. And so we've been talking about making changes in medicine. And as you know, our podcast is named Create Meaning in Medicine, Rewriting the Rules for Women in Medicine. You've talked about so much today, Diane. How would you say that you've been rewriting the rules in medicine?
That's such a big question. It makes me a little uncomfortable. I'm going to be frank about that. Like, I have to say how I've rewritten the rules. Okay, I think I've done it from the beginning as a child growing up in medical procedures, thinking to myself, okay, I want to become a healthcare provider and I want to do this differently. I will take that pause and listen. I do want to find out what is the patient's goal, what is important to them, and I'll try my best within the constraints of what I know is important to me or good medical care to give them that. I am their consultant, but it's a collaborative relationship. So focusing on really letting the patient know that we are partners, that sure, I have some expertise, but they have the best expertise in them. I think that is something I always try to do. Being a guest, being invited here, I think is such a privilege and an honor, and hopefully something we talked about might spark another clinician to change how it is for them in medicine. And I think finally continuing to do this and working on projects that really help women especially, but anyone, do that pausing and reflection to look at what helped make them the way they are, to have self-awareness about that, and to use their hurt to help others rather than, it's often said, hurt people. So transforming that hurt into help and growth is really an honor to be able to try to pay forward.
Thank you so much, Diane. I think we could talk to you for hours in a row. It's been such a great conversation. If someone wanted to learn more about what you've done, get in contact with you, what would be some good ways to find you?
My website is DianeSolomon.com, and my Instagram, which probably is my favorite, Dr. Diane Solomon, Solomon with all O's. I'm also on LinkedIn and X, that I still call Twitter. Those are some of the best ways to find me. And I'm working on a new project that should be rolling out in the next couple to 3 months. So keep watching my channels.
Thank you so much. Thank you again. We're so honored to have you. And with that, stay tuned because our next episode is coming right up.
Do you want exclusive resources and the opportunity to connect with us? Then visit createmeaninginmedicine.com now, where you'll dive deeper into how you can create meaning in medicine. And if you're serious about optimizing your results, take 2 quick steps now. Connect with us on the website and tune in to the next episode.